I told today in the okay. As discussed, we'll be having a few MCQs we're going to discuss here. Most of them are from your previous year questions, and few of them which were from the TNT, which is discussed in the Unacademy app. So you have an extra 3-month subscription for every 6-month plus subscription, which ends to today. You can use whatever code you have. If you don't have one, you can use Pathologist. Same goes with 1 year and above. You get an extra 6-month discount on everything 1 year and above. Fine. So there are few NEET PG 2023 targeted batch. This is one of them, and you have a TND batch which will also be there. With this batch will be particularly followed by your high yield division as well as PYQ batch. I hope that will be useful for you as well. Fine. And these are the subscriptions. If you're preparing for UPSC and MBBS first prop, there are few subscriptions particularly for that. You can use whatever code you have if you want to subscribe, or else you can use Pathologist. Fine. So let's start the discussion. So as usual, what we are going to have is I'm going to display a question, and I want guys whoever is online to comment on the answer. A little bit discussion in and around the question, and we'll go to the next one. We'll try to cover as many questions as possible so that we can get the discussions faster. Okay, Lakshmi. So for anyone who has gotten a bad rank, these are the only two options available. One, you want to take a batch, your see what you're going to get. That's the first part. The second part, you're going to prepare again. There's only one question which will decide which path you're going to go. If you want to prepare again, the only thing which I want you to tell is you have to put your 100%, no looking back. Don't think back saying that if I've not taken a drop, I'd have done better, right? If that thought ever crosses your mind, don't go for it, repeat. But if you put your 100% into it, studying consistently, not just for the last 3 months, from today onwards, you have to study consistently. 4-5 hours per day is enough. But consistent work till the exam, and maybe towards the exam, you can increase the number of hours of studying. If you can do that, anyone who's going to attend the exam will have a better rank next time, right? So this for everyone who has a dilemma that whether I will be able to do well or not. So this is the thing. If you're not able to do this, if you have any family commitments, you want to work, you want to do side by side something else as well. If there's a pressure, I would say that take a seat this time rather than doing for the next time. If you can give 100%, this for anyone listening to this, please go ahead to the next attempt. Fine. Okay, let's go ahead to this. Great, Ashish. I hope you're doing good. Good evening. So let's discuss here. Let's discuss more and more questions, and we'll learn more together. Fine. Okay, read through the question and give me the most probable answer. I just want you to comment whatever you think, and then let's read through the question. Look at the image. We'll decipher everything required for us. The image is bit in the corner. Let's see if I can bring the image to this side. Yes, I think this would help you a little bit. No. Okay. Thank you, Ashish. Thank you for kind words. So comment on whatever comes to your mind. Let's discuss to it. I want you guys to make an attempt. It's fine if you're wrong, doesn't matter at all. I would say there are few pointers which can help you here. Okay, and Namrata's gone for B. These are few pointers which might help you to come to a correct diagnosis. Fine. The things which I'm circling here might help you to come to a diagnosis. If I want to give you a clue, I would say that whatever I'm circling, they're all Jane cells, right? So that's a clue for you. Okay. Nikitan has gone with D, renal osteodystraphy Jyoti, and Naveen has gone with B. Let's read through the question and see what's happening to this bone and what is consistent in the history. A patient who is undergoing treatment for hemodialysis for a chronic renal failure undergoes a bone biopsy. The biopsy revealed an increased osteoclastic activity. Like the question says, I already have whatever you circle, all of them are the multinucleated cells, which are osteoclast bone, right? Osteoclast is one of the physiological form of a multinucleated giant cell, resulting in a microscopic picture as shown below. Which of the following radiographic presentation would be most consistent with the patient history and a biopsy? Fine. Let's look at all 4 options and see what will be present in a chronic renal failure. Before that, what do you think will happen to the serum calcium levels in case of a chronic renal failure? Will it be reduced or will it be elevated? This is a general question regarding chronic renal failure. The serum calcium levels in case of a chronic renal failure will be reduced, right? So you'll have hypocalcemia because of calcium loss there. So if a person has a chronic hypocalcemia due to chronic renal failure, what do you think will happen to the serum parathormone levels in that patient? Will there be hyperplasia of the parathyroid gland or it will be hypoplasia of the parathyroid glands? So we're just talking about the normal feedback mechanism. Kidney is not functioning properly. So serum calcium, like you guys said, is reduced. So because of that, what will happen to the parathormone? Will it be elevated or reduced? Parathormone will be elevated. Perfect, right? So I'm going to have a parathyroid hyperplasia. It will be elevated. So if parathormone gets elevated, so it's, as I said, it's a feedback mechanism. When parathormone gets elevated, there'll be more amount of your bone will be resorbed so that I can neutralize the hypocalcemia due to chronic renal failure. That's a basic funda behind this, right? So in other words, I need to find out which of these four possibilities will fit into hyperparathyroidism. Do you think in a case of hyperparathyroidism, there will be stress fractures? I might not have a bilateral symmetrical stress fractures in hyperparathyroidism. That's not the classical features here, right? Bowing of tibia, thickening of cortex, coarsening of trabecular architecture. Again, it's not a classical feature of an hyperparathyroidism. Utterly flash deformity, like someone said, it's more commonly seen in your storage disorders, right? But on the other hand, erosion of phalangeal ducts and subperiosteal resorption of the phalanges, right? In case of serum your hyperparathyroidism, here secondary hyperparathyroidism, can any one of you tell me one tumor which is actually not a neoplasia, but it's been termed as a tumor? One tumor which is very common in your hyperparathyroidism. What tumor is that? There's one tumor which is common in hyperparathyroidism. It's named as a tumor, but in real sense, it's not neoplasia. Have you heard about a tumor called as Brown's tumor? Perfect, right? Brown's tumor is a common one, right? So Brown's tumor, if you remember your radiological finding or a gross image of Brown's tumor, it will be extremely hemorrhagic mass. The reason for hemorrhage is this. Subperiosteal, there's lots of resorption of the bone, and Brown's tumor is very, very common in the phalanx, right? It'll keep on digging the bone because of the excess osteoclast stimulation because of a parathormone. That's what you can see here. These are nothing but whatever you're seeing here. It looks like an lacunae, right? There's nothing but my exaggerated house-shaped lacunae. It's becoming so huge, which is causing resorption of the bone. That's kind of nullifying the effect of hypocalcemia crossed due to chronic renal failure, right? So this image alone, if it's given, is a classical picture of a Brown's tumor seen in hyperparathyroidism, right? So am I right in saying that if I can correct the hyperparathyroidism, be it via taking care of the kidney problem or taking care of the primary hyperparathyroidism, will this tumor come back to normal? Will Brown's tumor resolve not exactly back to normal? Will it resolve on its own over the period of time? It will, right? Brown's tumor definitely will come back to normal on a long run because it's a metabolic disorder. It's not a neoplasia, right? It is just a metabolic disorder. So once I correct the metabolic disorder, it automatically comes back to normal, right? Okay, great. Let's go to the next question. Again, I want every one of you here to comment on the answer. It doesn't matter if you are writing the correct answer, it doesn't matter at all. The attempt is more important than getting it right, right? Okay, I hope you are able to see all the things. If not, just give me a second. Okay, I've just pushed it a little bit so that it's a little bit more visible at least. Okay, I hope it's a bit better visible. So comment on the answer. I'll keep quiet for the next few seconds. Comment on the answer. There might be two very close answers here. Whatever is being hidden here, it's phagocytosis of urate crystals, inflammation, synovial, and mycobacterium. Okay, so Aniketan and Lakshmi is gone for B. Anyone wants to add to the club? Jyoti has gone for A. Okay, let's discuss. I'm sure there's no problem in diagnosis here. It's an 51-year-old person who has endured multiple episodes of intense local pain involving the left foot, right? I'll just go a little bit higher, right? Okay. The pain has lasted for past 2 days. Physical examinations identify the right metatarsophalangeal joint and focuses tenderness, swelling, but minimal loss of mobility. This is more than enough for me to make a diagnosis. What do you think is the diagnosis here? What do you think is the diagnosis? The diagnosis is nothing but an acute gouty arthritis, right? And a painless 2 centimeter nodule over the ulcerated skin is present on the lateral aspect of metatarsophalangeal joint. When you have a nodule in case of a gouty arthritis, that means you're gouty tophi. I'm sure you must have heard about tophi. Tophi can be seen in everywhere. Your skin, subcutaneous tissue, it can be seen in muscle, it can be seen into the joint space as well. Fine. Beneath the eroded skin, a chalky white deposit of soft material is seen. Right, perfect. A 1 centimeter firm subcutaneous nodule on the extensor aspect of left elbow, which has been excised, and it shows a microscopic appearance here. Right. Gouty arthritis is due to deposition of your sodium urate crystals, right? So can I say the attacks of gouty arthritis is kind of proportional to the serum uric acid? Is that right or wrong? Like more the level of serum uric acid, the attacks of gouty arthritis will become more frequent. Is that right statement or wrong statement? If you have multiple answers of true and false, this might help you. It's kind of a right statement, right? So if I can control the serum uric acid levels to an extent, definitely the inflammation will reduce because it's due to the deposition of sodium urate crystal, right? Great. So I'm having lots of pink color deposit here. A sodium urate crystal in a histopathology will look exactly like this. The reason why I want you to remember this is whenever anyone talks to you about a sodium urate crystal or a gouty arthritis crystal, what comes to your mind? Needle shaped crystals or pink color crystals? The only thing which for most of the undergraduate which comes to your mind is the needle shaped crystals, right? So needle shaped crystals undoubtedly is one of the forms which is seen in the aspirate fluid. It is not seen in a biopsy. The needle shaped negatively birefringent crystals are findings seen in joint fluid aspirate. In a biopsy, you will see pink color structures like this, pink acellular structures. If I can look at a little bit at the corner, they might have a fibrillary edge which might not be exactly visible here, right? Okay, now let's go back to the question. There's no doubt in the diagnosis, it's gouty arthritis. Which of the following mechanism is most important cause of causing joint injury in this person? Right. Two things are directly ruled out, which none of you answered. Deposition of serum cholesterol into the synovium, definitely wrong. It's not due to cholesterol in the synovium. And granulomatosis inflammation due to Mycobacterium tuberculosis, obviously it is wrong. Right. Activation of neutrophils by phagocytosis of urate crystals is one of the options. And release of TNF causing acute joint inflammation is the other option, right? Okay. Now what I want you to look at here is, my question is about joint injury in this particular person. In this particular person, do you think the problem is acute gouty arthritis or a chronic gouty arthritis? The patient is having in gouty tophi, which means do you think it's a first attack or it's multiple repeated attacks? It's definitely, undoubtedly multiple repeated attacks, right? The patient has clinically has history for past 4 months, and the person has got a tophi. To form a tophi in gouty arthritis, it must be multiple repeated attacks. In an acute arthritis, in an acute gouty arthritis, I might not have a tophi. It'll just be an inflammation where there'll be swelling, redness, pain, that's all, and it'll automatically settle. Since the patient has had tophi, 1 centimeter firm nodule, it must be there for years. Patient might have noticed it only for the past 4 months, right? So repeated attacks of gouty arthritis, my acute joint inflammation alone is not enough for me. But this statement is absolutely true. Release of TNF will be there, which causes acute joint inflammation for sure. But in a patient with tophi, that's not my main cause. What is the most important mechanism is, why do you think there is release of TNF? And the question is targeting about the etiology and not my pathogenesis. The etiology is nothing but my urate crystals. When your neutrophils, which comes into the joint space after deposition of sodium urate crystals, it will eat the urate crystals. Urate crystals, they are inorganic substances. Do you think any WBC, be it neutrophil or a macrophage, can they destroy an inorganic substance like sodium urate crystals? They cannot. Since they cannot destroy sodium urate crystals, automatically they get activated. Do you remember something called as NET? A neutrophilic extracellular trap, kind of that? You must have heard it, right? So sodium urate crystals, once being engulfed, it will cause activation of neutrophils, and this activation of neutrophils via sodium urate crystals is primarily mediated by one of the important mechanisms of cell death. There are four different types of cell death I'm sure you must have heard: necrosis, apoptosis, pyroptosis, necroptosis. Of these four different things, which is the primary mechanism of activation in gouty arthritis? Is it necrosis, apoptosis, or necroptosis, or pyroptosis? Gouty arthritis is one of the leading examples for pyroptosis. So if pyroptosis is the leading mechanism, right? So what do you think will be the inflammatory cytokine which is especially involved in gouty arthritis? Is it TNF or interleukin 1? If it's pyroptosis, is it TNF or interleukin 1? It goes into the cell, enter the urate crystals, and they activate the inflammasome complex. Inflammasome primarily activates interleukin 1, which gets released outside and causes more and more and more inflammation, right? So activation of inflammation by phagocytosis of the sodium urate crystals is the etiology of this patient. I'm not denying the fact TNF will be there. TNF obviously will be there in any acute inflammation. But if interleukin 1 is there, I prefer it more because urate crystals cause pyroptosis, which is primarily mediated by interleukin 1. I'm sure you know interleukin 1 and caspase 4 and 5 and other things, fine. So since due to that cause, I'll prefer an option A more than often option B, and also keeping in mind it's a top 5 crystals. Top 5 is a constant source of sodium urate crystals and it keeps on activating the neutrophils, which will attract more inflammation and cause more pain to the patient, right? Okay. So let's say this is a practical question. It's not for an MCQ. Let's say that you are sitting in OPD and you're seeing a patient who came with a classical history of first metatarsophalangeal joint, gouty arthritic pain. First thing, how do you treat them? What's the drug you will give for acute gouty arthritis? I don't want answers from an MCQ book. I want answers from what you have read in your textbook. A patient has come with acute gouty arthritis. How will you treat the person? It's a very simple question. Management includes, do you want to do any lab investigation as well as to treat? NSAID is perfect, right? So Kirti as well as Sankdeep has gone for NSAID. Great. NSAID is obviously the right answer, right? You must have heard about colchicine, right? Colchicine is also one of the drugs for acute gout, right? So when a patient has an acute gout, NSAID is definitely better preferred than colchicine because practical experience, colchicine doesn't work more, right? I have an acute gouty arthritis, it's hereditary, and colchicine never works. NSAID, especially of NSAID, indomethacin works a lot. Coxibs works a lot, right? So these two are the drugs which works extremely well for acute gouty arthritis, so prefer them. Of the NSAIDs, indomethacin is the drug of choice for your acute gouty arthritis, right? So let's say that you have seen a patient with an acute gouty arthritis. Will you do an uric acid level or not? Is it recommended to investigate for an uric acid level? Blood investigation required or not? Serum uric acid is definitely required, right? So when you have a serum uric acid levels done, and let's say the serum uric acid levels is around 8 milligram percentage. Will you give uric, let's say 7 or 8? Will you give uric or not? Like allopurinol or your any of the uric drugs, or your asburicase or your febustatin? Will you give them? 7 to 8 is the serum uric acid level. Will you give uric drugs or not? Generally, for an acute gouty arthritis, urate modifying drugs or uric drugs are not recommended. If you have a consistent elevation of more than 8 and above, yes, I will give. Otherwise, it's not required at all. But if it's 7 or like that, an acute gouty arthritis just required NSAIDs, cold compresses, that's more than enough to take care of that. Fine. Okay. A few more things. Again, if you're seeing a patient with gouty arthritis, the gout is a symptom, it's not the disease. What are the predisposing factors for gout? What will you think in mind? Okay, this patient has acute gouty arthritis. These are the things I have to evaluate in this patient. What are the things you will evaluate in any patient with an acute gouty arthritis? Because I said it's a symptom. What do you think will be etiology of an gouty arthritis? The common etiologies again. Anyone? Alcohol. Great. Asha has gone in the right direction. The first and the foremost things you have to think of is food habits and metabolic problems. Never ever think of cancer. Cancer is the last chance of acute gouty arthritis, right? Like cancer is one of the last chances of acute gouty arthritis. Again, the problem with us is we read the rarest and the most deadliest thing because that's what they ask in an MCQ, right? We have to kind of change it. I said, right, I had an acute gouty pain. The first thing when I had first gouty arthritis was after my post graduation. First thing which stuck my mind was also cancer. I want to look at my CBC whether there's a leukemia which is causing a tumor lysis syndrome. Unfortunately, we are tuned for that. So when you go and practice outside, do not think of malignancies or carcinomas. That is definitely one of the common causes. I am not contemplating with that at all. For any patient, the common thing which happens in real life, I want you to remember it. Yeah, drug induced could be there as well. The commonest cause of acute gouty arthritis is metabolic causes and overweight, excess intake of alcohol, non-veg, excess protein will definitely precipitate gouty arthritis. Trying to control them. Extreme vitamin D deficiency, B12 deficiency are also proposed cause of acute gouty arthritis. After that, the chunk are inherited causes. Then the last maybe 1 or 2% could be cancers, right? So do remember them, but please keep them in the last. Don't think of them in the first, right? Okay, there's a few things with the gouty arthritis which I want you to know. Okay, let's go to the next question. Come on to the answer. Again, I have to unfortunately pull this outside. Just give me a second. Read the question, comment on it, and then let's discuss. It's a simple one. Okay, started the count with D. Anyone else wants to add, join? It's a very simple question, right? Okay, Jyoti, D again. Okay, Chandrasekhar Reddy, D again. D, 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 D. Okay, great. So we've got many of them with D and one option of C. Right? Let's see which is right. When you have a question regarding bone lesions, right? There are two things which I want you to remember for every bone tumor. First, age. Bone tumors in general are picked up via age. That's one of the very, very important clues, right? Let's take a tumor of Jane's. There are four options here. A Jane cell tumor. What do you think is the common age group of a Jane cell tumor? We have four options. We look at all the four options. We'll see, then we'll narrow down to the rest of them. What do you think is the common age group of a Jane cell tumor? Jane cell tumor, it's around 20 to 40 years of age, which kind of definitely fits into this patient. I'm not saying Jane cell tumor is the answer. The age group is around 20 to 40 years old, right? No, Jane cell tumor is not something which can be seen in the first decade. It's a bit on the young adult age onset, right? Fibrous dysplasia. What do you think is the age group of fibrous dysplasia? Fibrous dysplasia is a metabolic developmental anomaly. It's a developmental anomaly. So what do you think is the age group? This, like you guys said, it could be around the first decade or second decade of life. It's a bit of an early onset compared to the rest. Enchondromas, again, adults. Osteochondromas, what do you think is the exact age group of osteochondroma? Actually, for osteochondroma, there's one specific thing which is very, very important. Osteochondromas never start the pathogenesis after puberty. Because after puberty, the epiphyseal plate closes. Once the epiphyseal plate closes, osteochondromas do not form, right? So this patient having a 23-year-old in the right knee kind of is going to pull away from osteochondroma. The reason I have changed the age group from the original question had an age group of 15 years old, right? That's the perfect age group for osteochondroma. In general, most of the osteochondromas present in and around the puberty. Because after puberty, once the epiphyseal plate closes, it cannot grow much. It is just an exostosis or an osteochondroma, right? Let's read through the question. On physical examination, there's a point of tenderness 2 cm below the patella over the tibia. Radiograph shows a broad base excrescence projecting into the metaphyseal region of the upper tibia. So it's not a tumor from metaphyseal region. The written finding means is I'm having a tumor which is kind of projecting into the metaphyseal region. It's not arising from the metaphyseal region because, as I said, it's something which will arise from your epiphyseal-metaphyseal junction. It's an epiphyseal plate from which it's going to arise, right? So it's projecting into the metaphyseal region. So there's only one tumor which can project like this. That's a classical osteochondroma and exostosis, right? You must have definitely heard about symptoms of exostosis and multiple different things in your orthopedics. It's one of the important questions, right? Okay. So when I have exostosis, you must have definitely heard this as well. Your X-ray finding of exostosis, the topmost part, what will you have there? You'll have bone in the topmost part or cartilage in the topmost part. In any case of exostosis, bone or cartilage. The topmost part will definitely be made of cartilage, right? It will be made of cartilaginous cap. I think. Yes, great. Let's look at this image for a second and see if I'm going to see a cartilaginous cap or a bone, right? So this part is the image. If you look at this image, you can easily see that I'm definitely having a cartilaginous cap. And this part, which is on the top, is definitely bluish glistening surface. And what do you think this part is made of? This entire part, what is this made of? This part is exactly made of your bone, right? So the entire circle, what I've circled, is made of bone, and the topmost is definitely the cartilaginous cap, right? So this is classically seen in an X-ray itself. That's why I've had the term osteochondroma. It is both the osteo component as well as the chondro component, right? So when I have a patient with an osteochondroma, and you are the surgeon who wants to operate, you have done an X-ray, you know the diagnosis of an osteochondroma, right? Is it required for me to go for an MRI before the surgery or not? Again, it's a practical question. This might not come in an MCQ. Right? Is it required to do an MRI, or I can look at the X-ray, identify it's an osteochondroma, and go to the surgery? Do I need an MRI or not? Yes, no. It's a binary answer. 50% you are anyway right. Okay. MRI is required in case of an osteochondroma before going for a surgery. Actually, why MRI is required, right? I just erase whatever I drew. Just zoom into this a little bit. Okay. So this cartilage cap is something which is very, very important for me, because once the thickness of the cartilage cap increases, I have a risk factor. What is the risk factor? Let's say this cartilage cap is 5 centimeter thick. What do you think the patient might have a risk for? It's not just for the nerve compression. I have one more risk factor here. That's the reason MRI is more important, because X-ray cannot identify the thickness of the cartilage cap, right? So this thickness of the cartilage cap is very, very important. If this thickness of the cartilage cap exceeds beyond 2.5 centimeter, that's the cutoff given. Again, if you have an orthopedician saying having a different cutoff, I would say to go with an orthopedician's cutoff. Obviously, this entire thing is onus for the radiologist and the orthopedician, right? Okay, if you have a cartilaginous cap which is more than 2.5 centimeter, again, it's not about the embolus. Embolus is not my problem as well. It has a risk of chondrosarcoma, right? Perfect. Okay. Okay, perfect. The size can be anything, but if there's more than 2.5 centimeter, there is definitely a risk of an chondrosarcoma. That's all. So both the pathologist as well as the radiologist should look into the cartilaginous portion very carefully and say, is there any malignant transformation? If there is any malignant transformation, the treatment obviously is going to differ, right? So it can be of any size. I'm not saying that everything more than 2.5 centimeter will be cancer. There's more risk, that's all. So I have to evaluate it a little bit more stringently, fine? Post surgery, if it becomes cancerous, you should be able to say how to treat the patient. That's all, fine? That's the only important practical aspect for an osteochondroma and exostosis. Rest of that, I'm sure you'll remember. Okay, now let's look at this part alone. I want to have a quick look about this part. Fibrous dysplasia. There's a classical microscopic appearance of fibrous dysplasia. What is that? There's a named sign or a named pattern for fibrous dysplasia. What is the name of the pattern? You'll definitely know that. What is the pattern in fibrous dysplasia called as? It's named after some country's script. Chinese letter pattern, right? Perfect. When you have a Chinese letter appearance of a trabeculae, which means a very, very irregular trabeculae. I'll go back just for a second. See, this is a trabeculae, right? If you look at this pink color, this entire thing is a trabeculae. When this trabeculae is like this, It's not regular, it's just irregular. That's called as a Chinese letter appearance, right? It's a very, very irregular, ill-formed trabeculae. So I use the term Chinese letter appearance. That's very, very unique for fibrous dysplasia, right? Okay. Now, I have the term dysplasia here. So when do you use the term dysplasia? When you think of a benign condition or a malignant condition? The word dysplasia, I'm not talking about fibrous dysplasia. I just want you to remember this word dysplasia alone. When will you use it? When you think of a benign or a malignant condition? Generally, I'm going to use the term dysplasia when I think of malignancy, right? Like, for example, Barrett's esophagus dysplasia, which means it's kind of progressing to a malignancy, right? But I'm sure all of you here know that fibrous dysplasia is not a malignant condition. It is a developmental abnormality, right? Why am I naming the term dysplasia, which is useful for malignant component, for a developmental anomaly? I shouldn't use that, right? Because of the microscopic appearance, right? There's one thing you want to remember. Chinese letter pattern is one. The second and the most important thing in fibrous dysplasia is fibrous dysplasia lack an osteoblastic rim. That's very, very important. I'll tell you what does an osteoblastic rim mean. Give me a second. Let's take this for an example. There are few normal structures. I'm sure you know that. It's kind of a misnomer. Let's assume that, give me a second. Let's assume that's a bony trabeculae, fine? In a bony trabeculae, there are few cells in the center of the trabeculae. What are those cells called as? You know the name of the cells. There are 3 normal bone cells. What do we call these cells, which are there in the center of the trabeculae? We name them osteocytes, right? These are called as osteocytes. On the other hand, I have cells which will be on the, let's say here, I have cells which will be lined here. A single nucleated cells which will be lining exactly my bony trabeculae. What are these called as? I call them osteoblast, right? And like we saw in case of a Bronx tumor, you will have a lacunae where you will have a few more cells, right? You have a lacunae like this, where you have a multinucleated giant cells, which is an osteoclast, right? This is how a normal bone marrow space will be arranged. And here I have the bone marrow, here I have the bone marrow, right? So this entire thing is a bony trabeculae, where you have osteoblast lining the trabeculae, that is normal. I have pits, resorption pits, where I have the osteoclast, one or multiple of them. And in the substance of the bony trabeculae, I have something called an osteocytes. This is how a normal bone looks. So in other words, can I say your bone as well as my bone, which all our bone grows throughout life? Is that statement true? I don't stop at 18 years. This osteoblast, osteoclast, and osteocytes keeps on working till you are alive. Yes or no? That's definitely true, right? So what happens here is, normally my osteoclast will resorb the bone, osteoblast comes and lays down a bone, and osteocytes go into the deep part. Few of the osteoblasts later change to osteocytes and goes deep, right? This process is called as an mineralization. You have lots of remodeling process going on throughout life, right? So I remove them, I lay down, and I go back. I remove them, I lay down, I go back. So this is a very constant process. The remodeling process happens throughout life. It just strengthens the bone, that's all. So for me to form a layer of bony trabeculae, I need so many osteoblasts. So let's say I'm going to have one more osteoblast, right? Let's assume I have one more osteoblast. Let's try to draw a trabeculae. I'm having a trabeculae like this, and I am having only one osteoblast in the trabeculae, or no osteoblast at all, right? Randomly no osteoblast, right? When I have this trabeculae without any osteoblastic rimming, is it normal or abnormal? This growth of this trabeculae is normal or abnormal? I'm definitely going to call it abnormal, right? I cannot have a trabeculae without an osteoblast or an osteoclast or an osteocyte, right? So this trabeculae is an abnormal trabeculae. For anything abnormal, can I call it dysplastic? I can use the term dysplastic, right? So this is called as a dysplastic trabeculae. In case of a fibrous dysplasia, the trabeculae will lack an osteoblastic rimming. That's an abnormal trabeculae. Do remember them. When a trabeculae doesn't have osteoblast on its surface, that is normal. That is a feature of fibrous dysplasia. That is also a feature of osteosarcoma, right? Remember this, there's no lining, then I'm going to call it a neoplastic or an abnormal trabecle, right? As the reason, fibrous dysplasia is the name of a fibrous dysplasia, right? Though being a development anomaly, we call it dysplastic. Okay, okay, let's go through this question. Again, I said this is very, very simple one. I just want you to read the question and then we'll go to the different points. I hope it's visible and make it a little bit bigger. Go ahead. It's a very simple one. I want you guys to comment on the answer. Okay, Jyoti started it. Very quick answer. I hope it's the right answer. We'll discuss it soon. Anyone else wants to add to it? B. Okay, great. Let's read through the question. We'll see whether your diagnosis is right or wrong. Okay. Obviously, it's basal cell carcinoma. It's definitely the correct diagnosis. It's 76-year-old person. Well, Asha, can you refresh it once? Is it clear now? It's a 76-year-old person. Others, is it blurred as well? A slowly enlarging nodule in the right eyelid. That's actually more than enough for me to comment on basal cell carcinoma, right? A 0.3 centimeter pearly nodule. That's also very, very classical for a basal cell carcinoma. Surgery was done and multiple frozen sections were also done during the surgery, right? If you have remembered your surgery in either in ophthalmology or if it's been taught in general surgery, what is the type of surgery which is done for basal cell carcinoma? There's a name for that. The named microscopic surgery, which is done for basal cell carcinoma. What is the name of the surgery? What's the name of the surgery? You know that name of the surgery. You must have heard about something called the most microscopic surgery, right? MOHS. Most microscopic surgery is a very classical surgery done for basal cell carcinoma. What they do in most microscopic surgeries, yeah, more than layer by layer removing of skin, it's like it's more of the centimeter wise, right? Let's go back to the plain slide again. Let's say that there's a normal skin and you're having a tumor like this, right? A tumor, just a tiny tumor here. If it is a melanoma, can I say that you will leave like 2-3 centimeters on either side and then cut the tumor? You will have a margin of resection, right? You definitely have a margin of resection. I might give this margin of resection. I might cut here. I might have a margin of resection here. Then I might cut here, right? Like in a colonic cancer or in a gastric cancer, the margin of resection is 5 centimeters. That's what is the general margin of resection for GI tumors. Like that, you have margins of resection for every tumor. If it is a melanoma, I'm going to leave the margin of resection. But for a basal cell carcinoma, I generally don't do that. I don't want that. The reason I don't give a margin of resection for a basal cell carcinoma is, will it spread? Berlin-Ewing sarcoma's age group is also 10, first and second decade, that's 10 to 12, 20 years. It can be a little bit less than 10 years also. Generally less than 20 years the age group for Ewing sarcoma, right? We'll come back to this. Will basal cell carcinoma spread? Do they spread or they don't? Basal carcinoma generally don't spread, right? So let's say what we do is I exactly cut here. I know this is a tumor. I'm just going to cut here exactly, maybe a little bit leave 1 millimeter or so. Then I ask them to look in the microscopy. So this part will be sent for frozen section. In a frozen section, I'll be able to say whether the tumor margin is having the tumor or not. If it has the tumor, what I do is I'm going to add 1 more millimeter here. Again send for frozen section. I add 1 more millimeter here. Again send for frozen section. My margin of resection is just 1 millimeter. Very, very tiny. So each millimeter they cut, they're going to send for frozen section. And it's not only one side, like that for all the 4 sides and also the depth of resection, right? So in all these sites, all the 4 sites, as well as the depth of resection, for everything, I'm going to send a frozen section, right? That's your most microscopic surgery, right? Now, I'm sure all of you know that basal cell carcinoma never spreads. We always look at the fact. I don't look at why a basal cell carcinoma never spreads, right? If I have to improve, I have to ask questions to myself. I have to unlearn, I have to relearn new concepts, right? Let's see why a basal carcinoma never spreads. Right? Um, we'll go back to our basics. Whenever I'm in doubt, obviously the basic science is going to answer me much more than the highest advantages and the recent advances, right? Let's say you have a basal carcinoma. It's a tumor originating from your squamous epithelium, right? So from which layer of squamous epithelium do you think basal carcinoma originates? From the corneum or stratum basal? It's the simplest question I can ask, right? Obviously from the stratum basal, right? So if you take a normal skin, your skin and my skin, any person's normal skin, what is the layer on which your basal cells rest? The epidermis rests on layer. What is the layer? I'm sure you know that. Every epidermis rests on what layer? Let's assume this is my basal layer. This basal layer rests on one more thing. What is that called as and what is that made of? This part. What is that made of? That's a basement membrane. And a basement membrane is made of collagen, right? Perfect. So every basal epithelium of my skin lies on the basement membrane, which is made of collagen, right? So now let's assume I'm having a tumor of the basal layer, right? Let me go back to the straight line. I'm having a tumor of the basal cells. Let's assume the basal cell grows big. For every cancer, do I require invasion? It will invade, right? It will definitely invade. So when this basal layer becomes a tumor and it goes down, can I say that it will take your collagen along with it? It kind of becomes like a ball. That's a nest of tumor cells. The most important thing here is a layer of collagen. It has a layer of collagen all surrounding it, right? So this is my basal epithelial nest. It takes all the collagen surrounding them. So now it has gone into the dermis. The dermis also is made of collagen, right? So can I say the basal nest of epithelium, the malignant cell nest, has a collagen surrounding them, and my dermis is also made of collagen. Same thing. Will they retract with each other? If something opposite, it will attract. The same things will retract, right? So what happens is there'll be gap here. This is the collagen of base membrane. This is my collagen of dermis. They don't oppose with each other. There'll be a retraction artifact. So since my entire basal epithelium is surrounded by collagen, it kind of provides protection and doesn't let the cell come outside. Only when the cell comes outside, it can easily go into your metastatic pathway. Otherwise, it's not going to go into the metastatic pathway, right? So this retraction artifact and the collagen lining is the reason why a basal cell carcinoma doesn't spread. And if you carefully look at this, let's see if I can zoom this up. Whatever we read, we have to prove them. If you don't prove them, all of them are just facts. And facts are boring and useless, right? Let's look at this. I'm sure you know the basal cells, and I'm sure you know the color of basal cell. The color of basal epithelium is pink or blue? A normal color of basal epithelium, pink or blue? Basal epithelium is blue in color, right? But if you look at this basal epithelium, look at this part or any of this nest, look at the corner. Can I say it's pink in color? This corner, wait, this corner also. It's a bit pinkish, right? The corners of every basal cell nest here is pink in color, right? So now pink color basal cell nest. So whatever we read, that and basal cell nest will be surrounded by collagen because they rest on the collagen. Is that true? I'm having collagen surrounding the basal epithelial nest. The same image I've zoomed out. And if you look at this collagen, and this obviously is dermis. Whatever I write in D is dermis here. This is dermis here. So this also is made of collagen. So are you seeing the gap here? I'm having a space between the basal cell nest, which is invaded, and also the dermal collagen. So what I'm having is the retraction artifact, right? So this retraction space is the one which is going to help me the tumor cells to be limited locally, or whatever you must have read in your MCQs. They don't spread. They don't spread a lot because there's something which are being limited by the microscopy, right? Okay, let's go to the next image. Just give me a minute. I'll put this here. Okay, tell me the answer. Read the question. Chandrasekhar Reddy, yes, definitely collagen will be much appreciated on the Mason's strike room, but unfortunately, we don't use Mason's strike room for the simple reason I don't want this explanation to diagnose. When I see nets of basal epithelial layer in the dermis, I call it basal carcinoma. Yes, but as you said, it can be definitely much more appreciated on a Mason strike. Okay, come to the answer and let's discuss. Okay, Berlin has gone with the first one. D. Nevus, great. Dysplastic or melanocytic? Ayushi? D, great. It's a 10-year-old girl with routine checkup for health status. On a physical examination, there is a flat, uniformly brown, 2 centimeter skin lesion noted above the buttock, and the lesion is present since birth and has not changed in appearance. What is the classical diagnosis? You have a microscopic appearance as well. We'll look into the microscopy soon, but I just want you to look at the clinical history here. And obviously, one of the striking answers is a melanocytic nevi. It's not a dysplastic nevi, definitely not a basal carcinoma, and acanthosis nigricans is not something I'm going to see in this age group, and this description will not be like this, right? Now we have to learn about nevus, right? Can I say every one of us here, we have nevi? We do have nevi, right? Nevi is nothing but mole. All of us are mole. We don't describe a mole like this, uniformly brown in color and it's not changed in appearance from birth. And we don't go to a doctor for a mole. But unfortunately, foreigners go to doctors for a mole because they're scared that they can become melanoma, right? We have to understand what is a mole, why does it happen like this, and we look at the progression of a mole as well, right? Can I call nevus as a benign tumor of melanocytes? Is that right? Nevus is undoubtedly a benign tumor of melanocytes, right? So the image which I'm going to show is from Robbins. I'm sure some of you at least must have seen this image in Robbins. A very beautiful image of nevi, right? If you look at this part, the A, whatever has been marked as A, I want you to look from A to D. We'll look at each and every image here. All it's a very simple description, but has lots of pathology and science into it. So if you look at this image, the first part, you are seeing the brown colors, which are my melanocytes. In the normal squamous epithelium, which layer do you see melanocytes? Stratum corneum or stratum basale? Melanocytes is seen in stratum corneum or stratum basale in normally. Like you can see here, it is seen in stratum basale, right? It's if you have like 4-5 basal cells or 6-7 basal cells, it will be interspersed with my melanocytes, right? That's what happens in your normal skin. You, me, every person who is having a color will have this, fine. So here I'm having the growth of melanocytes. I'm sure all of you will accept that the melanocytes is definitely different color here, right? So when you have it's more in number, so obviously there's a growth. So I'm having growth of any cell. So can I say there must be some or the other proto-oncogene which is getting activated here? That's what causes this growth. Because without that, I will not have activation, right? Proto-oncogene is any gene which helps in cell division. Let's assume that the proto-oncogene which has caused the proliferation here is RAS. RAS is good or bad? RAS is good or RAS is bad? RAS mutation will generally result in cancer or no? It's a very simple statement. I'm sure you know the answer. RAS mutations generally do result in cancer, right? So one of the main problem for me is it's RAS mutation. I'm definitely worried about RAS because they can cause cancer. Only nevus has something called as RAS induced senescence. So what happens here is, let's imagine a little bit more so that you will have much more clear understanding of what happens. I'm having an RAS activation, not a mutation. Activation is always reversible. Mutation is something which is irreversible. RAS is getting activated, and like this, in Pujiger, I'm going to have an gene called as LKB1 mutated, not RAS, right? Now let's look at this. As I said, RAS is getting activated. I'm having lots of basal epithelium proliferation. Over the period of time, if it proliferates more like this, can I say it will drop down? It's becoming heavier and heavier and heavier. It kind of drops down. Yes. If it drops down, it has to get cut off from the parent population. Yes. I'll come to it, Arshi. KRAS mutation will be seen in colonic adenocarcinomas, not in Peutz-Jeghers syndrome. Right? Okay. If it's growing too much, it gets cut off from the parent thing. So here is where I have RAS activation. So once it drops, can I say RAS activation will stop? It will. So here, this cell kind of becomes smaller and will die. That's what will happen, or it will mature. Like you can see, as I said, the Robbins image are extremely perfect. Bigger cell, smaller cell, even smaller cell. It kind of undergoes senescence. It will not keep on dividing anymore because the RAF gets cut off. So over the period of time, this also will stop because it's growing, it's falling, it's growing, it's falling. The consistency is not maintained. So the RAS undergoes, the activation will be inactivated. The RAS will be inactivated, and this RAS replication has induced senescence in the melanocyte proliferation. This is called as an RAS induced senescence. So like you guys can see in the next image, the proliferation will stop. The proliferation totally stops, and the normal color of the skin also will be altered. The E image I'll show you, that's the last image, right? So I'm having 3 stages here, and I want you guys to name all the B, C as well as D. If you name B, C and D, I am sure you can easily know the clinical features of B, C as well as D, right? Okay. All of you have moles in your body, right? All of you have moles, right? So if you have seen a mole in your body, is it flushed with the skin or will it be elevated? Like, will it look like a macule or it look like a nodule? Every mole in your skin, will it be flat or will it be elevated? Or you have both the kind of moles, flat as well as elevated moles? It's a simple question, what you must have experienced in your body. If you have a mole, you can touch and see. It's elevated. Okay, I'll take Kirti's comment first. We'll look at the elevated mole also. Generally, moles are flat. They are not elevated, right? It's a macule, it's a flat, right? Right. Now, there are 2 guys here. 2 of you gave me 2 different opinions. One said it's elevated, one said it's flat. Other person also saying it's flat. But when there's a variation in my symptomatology, I need to explain with the help of my basic science, right? Now, let's look at this image. This image is having proliferation of melanocytes alone. This nevi, I'm going to use the term and junctional nevi. It is the proliferation is seen only in the junction of dermis and epidermis. So this nevi will be flat. It will have a very uniform color, like whatever the normal flat nevi you have will have like this, which is called as a junctional nevi. Now let's say I'm having this melanocyte proliferation which has gone deep into the dermis, which is broken off and gone deep into the dermis. Now, in simple terms, can I say that this nevi which has gone into the dermis, or the proliferation melanocyte which has gone into the dermis, will cause injury to the dermis? Will it? It has gone down. Will it damage the dermis? It will. When a damage happens, will it automatically induce fibrosis? Isn't that the next step for me? It should. So when it induces fibrosis, like Berlin and like Kitty said, will it become a little bit elevated? It should, right? So this damage due to the drop of the melanocytic cells will cause fibrosis, which will make the nevi a little bit elevated. I might not have like a nodule, it will be a little bit elevated. So if this mechanism is true, can I say the image D, which also has group of melanocytes in the dermis, will that also be elevated? It should be elevated, right? It not be flat, it should be elevated because that's how the presentation is going to be there, right? So I have 3 types of nevi here. Clinically, I can easily differentiate just by touching them. Macule, mostly junctional nevi. Elevated thing, maybe like a block, little bit of elevation, not a junctional nevi, any one of these. Right? We'll name the D component first, then we'll come to C. The D image, when you look at this image, where are you seeing the nevus cells? In the epidermis or dermis? Where do you see the nevi cell? It's a very simple question. I'm sure you know the answer. In the D image, I'm seeing the nevi in the dermis, right? So the D image nevi are called as simple as that. I'm going to call them an intradermal nevi. That's all. I'm seeing the nevus cells in the dermis, so I'm going to use the term intradermal nevi, right? Like in the first image, I saw the nevus cells in the junction of dermis and epidermis. I call it junctional nevi. But in option C, now the image C, I'm having your nevi cell both in the junction as well as in the intradermal. I'm having 2 things. Can I call them a compound nevi? right? This is called as a compound nevi, right? So I have three types of nevi. One is junctional, one is compound, one is intradermal, right? Now I'm going to ask you a little bit more deeper questions, right? So now within clinical examination, all of you here, just by touching, can differentiate a junctional nevi from a compound nevi and intradermal nevi. Can you? You definitely can, right? You just need a little bit of patience. You can definitely do it. Second component, you can even differentiate compound nevi and intradermal nevi on a clinical examination. You're going to answer me. If this image is correct, Robin's image is definitely correct. So my clinical examination is very, very simple. Now we look at option, the compound nevi and intradermal nevi. Which of these two has epithelial pigmentation? When I say epithelial pigmentation, the melanocytes in the epithelium. Which of these two has that? Which of these two will has epithelial pigmentation in this image? Definitely compound nevi, right? Perfect. So can I say in a clinical examination, compound nevi will be brownish in color? Yes. And an intradermal nevi, will it become hypopigmented? Because like you can see, I don't have any basal layer melanocytes here, right? So here the pigment change will be there, right? Perfect. And hypopigmented, tiny elevation, clinically, if it's a melanocytic lesion, I can think of an intradermal nevi. A normal skin pigmented or little bit hyperpigmented, elevated, a compound nevi. A flat macule, most likely a junctional nevi, right? Okay. Now let's go back to the question and see if this is fitting into the question. This is what our question was. On examination, a flat, uniformly brown, 2 cm skin lesion noted right above the buttock and is present since birth and has not changed in appearance. Compound or junctional or intradermal? I want you to pick up just from the question. Compound or junctional or intradermal? The answer is melanocytic nevi. They have not pinpointed what type it is. But if they are pinpointed also, you can easily come to a conclusion. It's flat, it's uniformly brown in color, so it has to be an. It's flat, right? Junctional nevi, right, Kirti? Kirti, a compound nevi will not be flat. It will be a little bit elevated, right? It's a junctional nevi, perfect, right? So this is how a junctional nevi will present. So you can easily differentiate junctional, compound, or an intradermal nevi just by a clinical examination. Microscopy is supplementary for me, right? I'm not going to the image part now. It's just supplementary here, right? Let's go to the next one. There's one more image of option E, right? I just want to look at the E image alone. Before looking at the E image, I want you to ask one simple question. I'm sure most of you guys know the answer for that, right? When you have a patient with a melanocytic nevus, what do you think is the origin of any melanocyte in my body? Is it an mesodermal derivative, epithelial derivative, or a neural crust derivative? What is the origin of any melanocyte in my body? Just the origin. It's obviously a neural crust cell, right? The neural crust derivative. So when I have a neural crust derivative, it is proliferated, it has gone into the dermis. In a dermis, it cannot stay as a melanocyte because that's not the normal location of melanocyte. Normal location of melanocyte obviously epidermis, right? It has gone into the dermis, right? So when it has gone into the dermis, I'll show that image ready. Just give me a second. Right? It has gone into the dermis. It is a neural crust derivative, but it cannot remain like a melanocyte. It has to merge with the surroundings. Tell me one more nerve derivative which can be seen in dermis. There's one more neural crust derivative which is there in dermis. Can I say all the nerve endings which are present in dermis will have the same derivative as like my melanocyte? They will. Yes, a neural ending. Yes. So what happens is the last image is going to happen like this. Just give me a second. I hope you can see the last image. So after an intradermal nevi, if it is a nevi, if it is a melanoma, it will not go and become mature, right? It becomes a nerve ending. This is called as a neurotization. This is a very, very classical finding From a nevi, it automatically becomes a nerve, which is called as a neuroticization of a nevus cell, which means undoubtedly 100% it is benign. It is not malignant at all. That's a fate of every nevus in your body. If it goes deep, it automatically becomes neurotized and will merge with the surroundings, right? So if this is correct, see, this is a very basic science. I want you to extrapolate with maximum extent possible, right? So I told you a nevi, which is a melanocyte, which is from a neural crust, it's changing to a nerve ending, which is also kind of a neural crust derivative, right? So can I say both of them, a nerve related tumor and a melanocyte related tumor, can they have the same immunohistochemistry? Is that possible? Just a wild thought. If both of them are originating from the same epithelium, is there a possibility both of them can have the same immunohistochemistry? Yes, perfect, right? Now let's put everything into the correct place. Tell me, what is the most sensitive marker for melanoma? What is the most sensitive marker for melanoma? You know the answer. I want you to tell the answer, that's all. The most sensitive marker for melanoma is, you must have heard about a marker called as S100, right? Perfect. S100 is a very sensitive marker for melanoma. You must have also known that it is not a specific marker. You know the reason now why it is not specific. If S100 is a marker for melanocytes, that is melanoma, can I also say that a nerve related tumor will also be positive for S100? Is that true? It is obviously true, right? That's the reason I said it's sensitive, not specific. At the same time, in CNS, have you heard that schwannoma is also S100 positive? You must have definitely heard. You must have definitely heard, right? Schwannoma is S100 positive. Melanoma is S100 positive. That's why I keep them as sensitive. Neurofibroma is S100 positive, right? So it's a neural crest marker. So whatever comes from neural crest origin, they'll be S100 positive, right? So it's sensitive, not specific. Whatever Chandrasekhar Reddy said, melan A, that's a specific marker because melan A originates from melanocytes. It's not from S100. It's not from neural crest. It's a feature of melanocytes, a mature epithelium. That's why melan A and HMB45 is a very specific marker, not your S100, fine? Okay, let's go to the next question. It's a very simple question. I'm sure you guys will answer in a jiffy. Look at the image, comment on the answer. I'll keep quiet for some seconds. It's a very simple question. It's an intestinal biopsy. It's a spotter actually. Okay, Berlin has gone with A. J has gone with A as well. APC gene, okay. 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 Diti has gone with D. Chandrasekhar Reddy for A as well. Okay. Now let's look at the image. Most of you guys answered A, an APC gene family history, right? So which disease? I'm sure you are suspecting a familial adenomatous polyposis, right? So which means this image should be suggestive of an adenoma or an carcinoma, right? That's a base for us understanding, right? If you make a mistake, that's completely fine. We have to learn from the mistake. Once you are able to understand, okay, what my way of approach is wrong, you will not repeat that, fine? So just answer the simple questions I'm going to ask, few leading questions. If this image is an adenoma or an adenocarcinoma, should that image have more number of glands? Yes or no? Yes, that's the definition for any neoplasm in the body. Every neoplasm should have more number of glands, right? So here, are you seeing more number of glands? I'm having such a huge lesion here, such a huge biopsy here. Right? Am I having more number of glands? I'm not having more number of glands here, right? I don't have more number of glands. I am having glands here, here. There are lots of places with no glands at all, right? So now whoever answered A, think and tell me, is this possible? Is this image be that of an adenoma? or an adenocarcinoma? No, right, it cannot be. So it's not an image of an adenoma or adenocarcinoma. So my option of your APC gene family history is unlikely, right? Okay, next come to the second option, pulmonary tuberculosis. Okay, sorry Jyoti, it's fine. It's not caseous necrosis as well, right? It is just necrotic for sure. I'm sure it's necrotic. Sorry for the image being skewed. Can you guys see the image better now? I'm sure you can. Right, so here, I'm sure if you can see this image, if you have missed because of the coverage, sorry for that. So this is my epithelium. I'm just drawing the epithelium here. And this epithelium is kind of ulcerated here, right? It's kind of ulcerated here. And again, I'm having an epithelium here. This part of ulcer, does it resemble an volcano? Does it look like something is burst outside and coming outside? Kind of bursting and coming outside, right? So what's happening is this called in volcano-shaped ulcers. That's a very classical finding for pseudomembranous enterocolitis. And this is a case of a pseudomembranous enterocolitis. And this image is from a sick admitted patient. Because a patient with pseudomembranous enterocolitis has only one predisposing factor. What is that? It's an antibiotic, a broad spectrum antibiotic. I'm not going to give a broad spectrum antibiotic for pulmonary tuberculosis, atrial fibrillation, or an APC gene history, right? It's a classical case of a volcano-shaped lesion, which is suggestive of pseudomembranous enterocolitis. We'll see why this volcano. What happens normally here is, can I say this is a perfectly normal intestinal biopsy? You have a perfectly normal crypts and glands, right? Okay, this is my epithelium. You have your goblet cells. It's perfectly normal, right? So when the Clostridium difficile toxin is there, like you have an cephalosporin or any of the drugs, broad spectrum antibiotics, which will destroy the commensal, so the Clostridium difficile becomes more powerful. So when the Clostridium difficile toxin comes here, that will act as a ribosylation of GTPase. This ribosylation of GTPase will disrupt my epithelium, will damage all the epithelium, and the organism enters inside. When any organism enters inside, will it elicit an body's immune response? It will, right? It automatically elicits a body's immune response. So it's an acute inflammation. There'll be lots of pus cells coming inside. When the pus cells comes and there's an epithelial disruption already, and all these pus cells will erupt outside because they are under pressure. All of them erupts outside. That looks like a volcano, right? There's a classical description of a volcano-shaped lesion, which looks like a volcano. The image what we saw. So that's a classical finding seen in pseudomembranous enterocolitis, which is Clostridium difficile induced diarrhea, right? It's a simple spotter. Sorry for the image being cut off. Okay, I'll go out first itself. So again, a simple question. I hope the entire thing is visible. Comment on the answer. Let's discuss in a few minutes, few seconds. Answer? Okay, great. Let's look through a question. It's a very simple spotter. Which of the following is true regarding the Zygote cells given in the slide of gastric cancer? They have not troubled you much. They are told that they are Zygote ring cells, right? I'll just zoom this image a little bit to identify where are these Zygote ring cells. What are these? Can I call all of these as a normal gland? That's definitely a normal gland, right? I just put dots for every normal gastric gland you're seeing here. You have a gland, you have a lumen. That's perfectly normal, right? So when you look at this part, can I say whatever I'm drawing here, they don't have glands. There's no gland formation here at all. You don't have glands there, right? So you don't have gland formation at all here. At the same time, if you look carefully, are you seeing cells with an extremely clear cytoplasm and nucleus pushed to the periphery? You can see the nucleus here pushed to the periphery. Can, right? So all these areas where I don't see the glands, they are composed of signet ring cells. So that's the signet ring cells which has been described in the question, right? Now let's look at the question. First and the foremost thing, signet ring carcinoma is something which is, you have a term called as a diffuse gastric carcinoma. In a patient with a diffuse gastric carcinoma, you see lots of signet ring cells, right? What is the mutation seen in a patient with a diffuse gastric carcinoma? I'm sure you know the answer. Diffuse gastric carcinoma patients will have E-cadherin mutation, right? So E-cadherin mutation in case of a diffuse gastric carcinoma, will it be a gain of function mutation or a loss of function mutation? E-cadherin is a tumor suppressor gene. CDH1 is a tumor suppressor gene which produces E-cadherin, right? Gain of function or loss of function? It has to be a loss of function. Perfect. So if it is loss of function, my option B, E-cadherin staining will be useful to recognize them. When I stain the signet ring cells with E-cadherin, can I identify them? It will be lost, right? So it will not be helpful for identifying them. If it is negative, which means that there's a problem for me, right? So E-cadherin negativity will be positive, which means they are tumor cells. So staining will not help me to recognize the tumor cells, right? So this answer is wrong. I don't have a very classical criteria for 30% of them should be there. In a biopsy, if I see good amount of signet ring cells, that's enough for me to call it a signet ring carcinoma. Though the 30% cutoff was previously used, which has been now kind of removed from the last WHO itself, so I'm not going to go for that, right? The pattern of linitis plastica. The gross appearance of signet ring carcinoma is linitis plastica. And the question option says that it doesn't correlate with the presence of signet ring cells. It perfectly correlates with the presence of the signet ring cells. So this is also a wrong statement. All of them are wrong statement. Actually, the signet ring cells doesn't require anything. It's a pure morphological criteria which is going to help me in the diagnosis, right? Let's see a quick look about what is a signet ring carcinoma and how to pick them up, right? So this is what happens. This is a perfectly normal gland, and let's assume for an instance, we are going to understand what is E-cadherin. We're going to learn why E-cadherin loss will result in a cancer and why I'm going to have signet ring cells, right? So let's assume this cells between them, can I say the cells here, this part they have E-cadherin, because the normal function of E-cadherin, like you guys know, they are cell to cell addition, right? So I have two cells here. Can I say these two cells will be connected by E-cadherin? They will be. That's a normal function of E-cadherin, right? That's the absolute normal function of E-cadherin, right? So here, when I have a cell which is dead in the sense any GI epithelium will die and will regenerate, right? So when a cell dies normally in the GIT, can I say the E-cadherin connection between these two cells will be lost? In other words, my body will recognize that there is no one to bind here. There is no person to bind here. That means there is no contact. Whenever there is no contact with my body, what my body automatically does is it will replace this. It will produce a new cell here. That's how E-cadherin works. I'm having two cells in contact always. When a cell dies, the contact is lost. So my body knows there's a need to produce a new cell, so it produces a new cell. This is normal function. Now let's assume a patient with loss of E-cadherin. When there is no E-cadherin at all, will my body think that there is no one surrounding? I'm having a cell here. I have loss of E-cadherin, it's a mutation. So will my body think there's no one surrounding here? And will they produce cells at every direction possible? Because there's no E-cadherin connection in all the directions, right? So what happens is a new cell comes here, a new cell comes here, a new cell comes here. When the new cells come, they also don't have E-cadherin. So again, they produce new cells here, they produce new cells here. So will I have n number of cell proliferation? And that results in a cancer, right? So what happens in E-cadherin loss is there's a process or the pathogenesis of E-cadherin loss. So when E-cadherin loss is the pathogenesis, when there is no cell to cell addition, can I form a gland? To form a gland, I need cell to cell addition, right? I can never form a gland. When I cannot form a gland, it is going to give a signet ring appearance. Uniform cells, right? So I am not having anything, so I'm not going to form a gland. I have this poorly discohesive cells. But like the slide says, the cells are still functional, right? I'm having cells that are still functional. when you have a GI cell, a foveolar epithelial cell, which is still functional, what do you think is the function of normal gastric foveolar epithelium? What do they secrete? I want the foveolar epithelium. I don't want my parietal or my chief cells. What does the epithelium of stomach secrete? It's a very simple question. You should know that. What does the epithelium of stomach secrete? They secrete mucin, right? My chief cells secrete acid. To nullify the effect, my foveolar epithelium secretes mucin, right? Perfect. So when a cell secretes mucin, the cell is still functional and the cell doesn't have a gland, so they don't have a duct, so they cannot secrete the mucin outside. They cannot secrete it outside, but still they are functional, they synthesize mucin. So can I say, when they synthesize mucin, keep on synthesizing mucin, they are not able to release the mucin. Will all the mucin accumulate inside the cell? It will. It has to. And when it accumulates inside the cell, won't it become like this? Like a fatty liver cell? I'm having lots of mucin accumulation here. That mucin accumulation pulls my nucleus towards the periphery. That looks like a signet ring morphology, right? That's how a signet ring cell looks. In a microscopy also, we have the same appearance. I'm having a cell filled with mucin. Mucin is clear in my microscopy and the nucleus will be pushed to the corner, right? As a completely pure morphological diagnosis, the signet ring carcinoma of the stomach, right? And if this is true, and I don't have any glands at all, can I say all these signet ring cells can spread along the entire wall of stomach because they are in the lamina propria and the submucosa? They don't have a gland formation. They is dispersed. They can easily spread all along. If they spread all through the wall of the stomach, first question, the prognosis is poor or good? The entire tumor spreading throughout the wall of the stomach, good prognosis or poor prognosis? Definitely a poor prognosis, right? So this patient will definitely have poor prognosis. That's first point. Second thing for me is, when the cell spreads throughout the wall of the stomach, like what we read in your nevus, it's invading, it's damaging the underlying tissue. Will there be tissue damage? Followed by that, will there be an wound healing? And will the patient have fibrosis? Is that true? Because these tumor cells are spreading all along. Chandrasekhar Reddy, I'll come to Indian file. It's not seen here, it's seen in breast cancer, right? It will spread, right? It will spread all along. It will cause damage all along wherever it spread, and it will cause fibrosis. That fibrosis will make the wall of the stomach extremely thick, isn't it? It will definitely make extremely thick, right? So thick wall of stomach is what is called as linitis plastica. If you look at this image, this is your gross appearance. Linitis plastica is a gross appearance, not a microscopic appearance. I'm having a very thick wall of stomach. Wall of stomach will not be this thick generally. It's very, very thin. An extremely thick stomach, because just for understanding, I'm having microscopic tumor cells going all along this corner. Right? It's going all along this corner and it's causing the problem. Right? It's causing the problem. Right? Fine. So this week already coming to your question, why Indian file appearance? Right? Let's look at something here. I'm sure you are clear with the appearance of signet ring cells and why it came and everything, right? So here in stomach, I have lots of loose parenchyma, so my cells can spread easily. So as I said, it can go through the entire wall of stomach. On the other hand, when I take breast parenchyma, is it firm compared to my stomach parenchyma, or it's more looser? The breast parenchyma has fibrous tissue. The breast parenchyma is firm. So what happens is, in a breast parenchyma, let's say it's already like this, which has lots of collagen fibers, and having tumor cells which are proliferating. The tumor cells cannot spread as easily as stomach. So what happens is, they get stuck between two layers of fibrous tissue. They're kind of getting stuck between here, right? So can I say they should be one behind the other? What happens here is, they can move all around because they're very loose parenchyma. But the breast parenchyma is not as loose as that, so they get stuck between two layers of fibrous tissue. So it looks like an Indian file pattern. Here, it looks one behind the other. It's the nature of the tissue, not the mutation. Mutation is the same reason for having the cancer, loss of contact inhibition, but the appearance looks a bit different. Fine. Okay, is that clear? Okay, we'll call it off today here, and let's see together. I will have a class at 10 o'clock. That's mainly for postgraduates. If you're interested, you're more than welcome to join that as well. Fine. Do you have any doubt? If you have any doubts, do let me know. Let's just call it a day. If you guys don't have doubts, fine. Call it a day. I'll try to create more MCQ discussions for you in the YouTube as well as special classes. I'll be starting a series of special classes starting from maybe a couple of days down the road. From next week, we'll go chapter wise so that if you're preparing for your upcoming NEET exam or FMG, if you want to prepare, that'll be useful. And all of them will be free. You're more than welcome to join the special class at the Unacademy app. Thank you. Bye bye. Berlin, that's completely fine. See, when I say there's a very famous statement by one of my professors: tumors don't read textbooks, right? So what we know is I have a Gaussian distribution curve of patients which are predominantly in the first and second decade. So definitely you can have patients later than that also. Right? You can even see Ewing sarcoma in a 40-year-old person. That's completely fine. But not all of the Ewing sarcoma in 40-year-old. Most of the Ewing sarcoma will be first and second decade only. Few of them will be there are outliers for sure, right? That's the reason you must have seen that, right? Okay, thank you for your time. See you soon. Bye bye.